Alrighty, everybody. Last chapters, chapter 17 and 18, and then a little PS from me at the end. So let's get into it. So mental health professionals, important to understand the difference between psychiatry and psychology, okay? So psychiatrists prescribe, okay, their main role is to prescribe medicines, and psychology is more like testing and like counseling and those types of things. So general overview, anxiety and depression and really all like psychologic disorders occur when the person's own ability to self-regulate or repair is diminished. Whatever they're dealing with is past their capacity. And there can be signs that are emotional, mental, behavioral, or even physical signs, okay? And there's pretty much always a variety of factors at play when somebody's either anxious, depressed, or anywhere on this spectrum, okay? And the biopsychosocial / spiritual model is a framework for trying to understand these responses. And it's essentially this pie chart, and we'll look at it in a second, that shows us how different parts of the pie may be larger or smaller at any one time, and all of them play a role in people's symptoms. So this is that pie chart. Okay, so there is a huge part of anxiety and depression that is genetic. Oh, that's a lot thicker than I wanted. That is genetically based. Okay, there's a genetic predisposition. And then, you know, people's personality and temperament plays a different role. Like some people are naturally just more easygoing and laid back, and some people are naturally just a little bit more on the anxious spectrum. Family dynamics can be huge, okay? Whether that's either it's a protector or an aggravator for people, okay? Your physical health, obviously, if you know you're this rock star athlete and then you tear your ACL and have to miss the season or whatever and go through all this rehab, like that's really going to weigh on your mental health. Comorbid conditions, things like asthma or type 1 diabetes, those types of things. Resources and coping, like financially, like do they have the money to pay their bills? Those types of things. And then acute and chronic stressors, which can be anything from, you know, grades to just like relational problems, like the whole spectrum. And just keep in mind as we have these conversations, these aren't specific to athletes, okay? Like essentially the entire world right now should probably be on antidepressants, or at least be in counseling. The anxiety and depression, first off, there's very, very few people who only have anxiety or only have depression. Most people, it occurs on it's on a spectrum. Okay, so maybe some people tends to have more anxious symptoms. Most of the time, they also have depressive symptoms as well. And like I said, it's just super, super prevalent, especially right now with all of the stressors that people have been under for the last couple of years. So this just breaks down more of the different disciplines that are that provide mental health services. Psychiatry, psychology, marriage, couple and family therapy, social work, psychiatric nursing, like even general practitioners, like I'm a family medicine nurse practitioner, I can prescribe. So I would say that it's much broader than just this table. So implication for participating in athletics. So, and we're talking here about like, you know, any type of mental health issue. So like with most conditions, the earlier we identify, the earlier we treat it, the better, okay? And mental health is not abnormal to that. But there is a huge stigma surrounding it, that somehow you're crazy or you're weak or you're not strong enough or you're attention seeking, or the list goes on and on and on. And so this stigma really inhibits people from admitting that they have problems, admitting that they're struggling, and so the biggest thing is, and I feel very honored that people come to me and kind of bare their soul and say, you know what, no, I'm not okay. And oftentimes that even just saying that sentence or making that appointment is very, very hard for people. So you may find that people come to, or athletes in particular, speak with you guys first because you may be a little bit less intimidating than making an official appointment with someone to talk about it. Okay. And then obviously any restriction going forward depends on the assessment of the athlete's level of functioning by both the athlete, the coach, and the athletic trainer. Okay. And so it doesn't necessarily mean that if you come forward and say that you're depressed or that you're anxious that you can't participate. Okay. But this is a great example, okay? And honestly, pretty amazing for the people, for athletes and just people around the world to be able to see someone say, you know what, I'm not okay and I'm not going to do it. And that's okay too. And obviously there's a lot of factors around Simone Biles' decision, and I think like her aunt had just died but no one knew, but essentially she said that she wasn't in an emotional state to be able to compete, and she decided to withdraw instead of risk hurting herself, which is pretty major. That's like, you know, the Olympics. It's not like a small thing. So that was, you can think what you want about it, but being able to even just admit on a small scale that you're struggling is a giant act of bravery. But then to admit to like the whole world and your country who's counting on you and all the hype that goes into it, that's huge. So something else to think about is, you know, suicidal or homicidal concerns. We are all mandatory reporters, meaning if we think that someone is at risk to harm themselves or others, we must notify the authorities. And for you guys, it's essentially you just got to get somebody else involved. You want to pass that buck off. It's important to remember that there is a distinction between passive and active thoughts of death. So passive thoughts of death would be more like, you know, it would be okay if I just went to sleep and didn't wake up the next day. I'm not really going to do anything about it, but, you know, I wouldn't be upset about it. Versus active thoughts of death are like actively making plans or something like that in order to end their life. And really with all of this, stress is the common denominator. Unfortunately, like in our day and age, it's almost like a badge of honor to be like ridiculously busy and super stressed out and overworked and overtired and all of these things. But stress is kind of the underlying current for all of this psychologic disorders. And so I called it essentially a garbage word for the impact our physical, emotional, psychological, and social experiences have on us, because there's a whole lot that is wrapped up in that. And ineffective stress management contributes to psychological and substance use disorders. Okay. And if people do not learn how to manage and cope with their stress, eventually they decompensate and they have decreased effectiveness in whatever it is they're doing, and ultimately failure in what they're doing. And obviously that's a cycle we would like to break. So the COPE inventory is something that your book highlighted that you guys could use as a way to know how an athlete is coping with stress in their life, and also get a better sense on like what type of coping strategies are they using and to what extent, and are they using them successfully. I never used the COPE inventory before, but I just googled it, and this is generally what it looks like. It's like a rating scale like most things in life, and they just go through to be like, I've been trying to work or find other activities to take my mind off things. I've been saying to myself, this isn't. So obviously if somebody is say number 2, I've been concentrating my efforts on doing something about the situation I'm in. And if they say, yeah, I'm doing that every day, versus I've been saying to myself, this isn't real, those are obviously very different levels of coping. Okay. Generalized anxiety disorder, meanwhile, is like, if you have to put it simply, people who are worried or nervous about many or most things in life. But the important distinction is it has to be going on for more than 6 months. And so it's designed that way so that if you're under an acute time of stress or anxiety, like for me when I was getting ready to take my boards, like that, like me being stressed or anxious in that time isn't enough to qualify as general anxiety disorder. It had to be a longer term. And these people have difficulty controlling the worrying. And then they have 3 or more anxious or anxiety symptoms. And this anxiety impairs social, academic, occupational, or relational functioning. And very often people have physical manifestations of their anxiety, whether it's palpitations or headaches or nausea or diarrhea. There can be a whole host of different things that it's actually their anxiety manifesting. And sometimes people even have panic attacks, okay? And panic attacks can be that like stereotypical hyperventilating, like freak out moment, but it can also be a lot more subtle, okay? Sometimes people experience chest pain or shortness of breath, and episodes seem like they come out of nowhere, but they're often in response to accumulation of a bunch of different stressors. And then later on, people are often able to identify like an acutely stressful event that's likely to trigger a panic attack. Okay, and I have some patients that, like, their version of a panic attack is they just go and curl up in a ball in the corner. It's not all that much of an outward thing. Post-traumatic stress reactions. So this is like acute stress disorder and like post-traumatic stress disorder, PTSD, that we hear about a lot more often. These are reactions in response to exposure to life-threatening events or other situations outside the normal range of human experience. Okay, and we don't get to decide what is a traumatic event for someone. Okay. A big example that I deal with, because I work with a lot of like postpartum moms, there's an awful lot of moms that get PTSD from their delivery, from the delivery of their baby. And some people might think, no, that's such a good thing, that's such a happy thing, but I mean, obviously it depends on how it goes. And that could be something you have to process through, okay? And so we don't get to decide what is traumatic to someone else, okay? And then oftentimes these people will go to great lengths to avoid situations, feelings, or thoughts that are associated with that original experience. And oftentimes they re-experience that through intrusive and distressing recollections, images, thoughts, perceptions, dreams, illusions, or hallucinations. These are those so-called like flashbacks, okay? And they can have strong physiologic reactions to any of those triggers. And if it's left untreated, this can really play a role in physical, emotional, and social difficulties for many, many years. So obsessive-compulsive disorder is persistent thoughts, impulses, or images about exaggerated or imaginary circumstances, and their hallmark is kind of intrusive thoughts. Those like, did I check the door? Did I lock the door? I don't remember if I locked the door. And it just goes on and on and on. And oftentimes it's compulsive or repetitive behaviors that are paired with obsessions, okay? The locking the front door is a big one. Turning the oven off is a big one. Often focuses on contamination, doubts, loss of order, horrible trauma, and sexuality. And so oftentimes these people think that like if they don't go through their routine of like, tapping twice, checking the door 4 times, opening the closet 3 times, whatever it is, that something really bad will happen. And if you truly believe that, it can be very hard to stop yourself from participating in those. These are some more examples. So if they're worried about contamination or infection, they would wash their hands or clean excessively. Sometimes it's requesting or demanding assurance, ritualized behavior, certain order to getting dressed, making sure doors are locked, checking to make sure appliances are turned off, religious or psychological correction. There's a whole host of them. Okay, and then when you think about depression, like I said, there's quite the continuum. Like, there's people who are very, very depressed. And then there's like the walking depressed that like you wouldn't really know it. They get up, they do their job every day, they go about their business, but still experiencing that depression. And then seasonal affective disorder, or SAD, is 100% a real thing. I don't know much about you guys because you guys don't have the mountains, but like here, we have like the sun comes up at maybe 8 o'clock and it goes down at maybe 3 or 4, something like that. And so like for me today, I am at work the entire time the sun is out. So it's really easy to get into that seasonal affective disorder where it's just you have no light, it's dark, it's gray, it's depressing, those kinds of things. And so depression can result in changes in physical, mental, emotional, relational, or spiritual well-being. And these are just some examples of some situational and developmental stressors in athletes, but like I said, also, in the general population. So not meeting performance expectations of self or others, change in playing status, coaches, teams, partners, death or serious illness in family member, relationship breakup, major life transitions, even birth of a baby. These are red flags for depression and like suicidal ideation. Okay, so depressed mood, diminished interest in usual activities, irritability or anger, diminished performance, substance abuse, social withdrawal or isolation, preoccupation with escape or death, and then like giving away possessions. So now we're going to talk some about eating disorders. So anorexia nervosa is a big deal, potentially life-threatening condition with long-term mortality rates approaching 20%. And it's the refusal. I disagree with this definition, and I'll explain why in a minute, but this is how your book defines it. To say refusal to maintain weight at a minimum of 85% of expected ideal body weight. To a certain extent, that's like stereotypical anorexia, but anorexia can be a lot of different forms. Anorexia is this intense fear of gaining weight or being fat to the point that they're severely restricting calories and or overtraining. Okay, and it's because of a disturbed perception of body weight or body image, and overtraining is a common compensatory behavior with athletes, okay, in order to help maintain that slim figure. And this is why I disagree with that definition. Both people can have anorexia. Okay, so just because the one on the left BMI is greater than 85% or whatever, she can still be, only eating 500 calories a day and exercising, walking 6 hours a day. I don't know, something ridiculous like that. Both, like, we cannot just assume that because somebody is overweight that they do not struggle with anorexia, okay? It's not that cut and dry. And the person on the right can be malnourished, and the person on the left can be malnourished, okay? Both are, we can't just make that assumption. Okay, so then bulimia is more common than anorexia, but can also be life-threatening. And it's characterized by, binge eating followed by an inappropriate compensatory act to prevent weight gain. And combat that sense of feeling out of control. So sometimes then it's restricting food, sometimes it's vomiting, laxative or diuretic use, exercise. Like stereotypical bulimia is binge eating a large amount in secret and then like purging. versus binge eating disorder alone is actually the most common eating disorder. And I would more identify this as more like emotional eating. So people who eat large amounts in order to try to help themselves feel better. And they eat to the point that they cause like emotional or physical discomfort. Okay, so substance use and dependence, and we're going to talk about, the different spectrums of these. So we're talking about the use of mind or mood altering substances can take many different forms, including use, misuse, abuse, and dependence. And unfortunately, social messages around drug and alcohol use conflict and really exacerbate these problems, okay? And then, as we know, peer pressure among younger adolescents often encourages alcohol or drug use. And then denial is a huge complicating factor. So use, drug use, or substance use is using the substance without meaningful impairment. So, like using it, say, if it's a narcotic, as prescribed after, ACL repair, or if somebody has generalized anxiety disorder, using their lorazepam in order to help prevent panic attacks, those types of things. It's appropriate use. Misuse is the occasional use of a substance to excess, resulting in impairment of one's ability to function. This is also, I would also say that this is maybe like more than prescribed, okay? Because sometimes like I'll start somebody on oxys for something and it like knocks them out and they cannot get out of bed. So it's like, oh, okay, that dose is too high. But that doesn't mean they misused it. I would say is as if they purposefully use above prescribed, or in the case of prescription medicines, but also obviously illicit ones as well, with the goal of causing an impairment of their ability to function. Versus abuse is the maladaptive pattern of substance use occurring within a 12-month period that causes impairment in social or occupational functioning. And if they continue on this pattern, even despite the ongoing negative consequences. So these are just some examples of like how our social construct or whatever encourages these types of things. And I would say alcohol is the biggest one that is misused, okay? Because it's like our culture, and like the wine mom is essentially normalizing alcoholism, as well as like the beer 30, or the beer gardens, or just how much is surrounded by this is essentially promoting that you have to drink a lot of alcohol to have fun or do whatever. And it's important to remember that like the official recommendations for alcohol use for females is no more than 1 drink a day, and for males is no more than 2 drinks per day. And those are standard servings. So like 4 ounces of wine, I think it's 8 ounces of beer, and then 1.5 ounces of hard alcohol. And so oftentimes what I hear from my younger patients is they're like, oh, I'm not a big drinker. I only drink occasionally. I'm like, okay, so on a day that you do drink, how much do you drink? And they'll be like, oh, well, 6 or 7 drinks. So that's actually a heavy drinker. They're just not drinking every day. They're just binging on the weekends. And so it's important to kind of quantify that as well as to quantify when they say they're having 6 or 7 drinks a day, what size are their drinks? I don't know if you guys have seen in Costco, there's like a wine glass that's like this big. And I'm like, okay, obviously that's not just one glass, okay? So anyways, just a couple of things to keep in mind. And oftentimes learning these types of things can help us with a little introspection into ourselves also, because unfortunately these messages run pretty deep. And like I said, nobody is immune from anxiety, depression, or even substance use. Okay, so dependence or addiction is a maladaptive pattern of substance abuse occurring in a 12-month period that leads to significant impairment or distress. And it's characterized by either a tolerance or withdrawal. Okay, and so I have some people that I manage their chronic pain medications, and they are absolutely dependent and addicted. Okay, and that's a hard line to walk. Okay, between when you're on these types of medicines for decades, like how do you not get addicted and such? And that's part of the problem, is that they are so addictive. And up until recently, there wasn't a lot of regulation around prescribing them. So attention deficit hyperactivity disorder, or ADHD, is a neurobehavioral condition that impairs a person's ability to sustain attention or to control activity and impulses in at least two settings. So what that means is like both at school and at home, at work and at home. Most of the time ADHD is diagnosed in adolescence, but most often it's diagnosed if you're the hyperactive little boy that just like keeps bouncing in like the second grade. The more inattentiveness, like the daydreaming, zoning off, those kinds of things, is more common in women and is often missed until a lot later in life. Then there's a high comorbidity between ADHD, substance abuse, mood and anxiety disorders, and such as, you know, these people are trying to find something to help them feel better. And so then these are the stages of readiness when it comes to like quitting or stopping a behavior or an activity, okay? And the very first thing is that like the athlete needs to be willing to recognize that a problem even exists, okay? And then they go through the pre-contemplation stage, the contemplation stage, the preparation stage, action stage, and follow-up or relapse prevention stage. And so I really just bring these up because if somebody isn't willing to even acknowledge that it's a problem, like you can try to address it, but obviously you're not going to make a lot of ground there. You just need to continue to assess and say, you know what, these are some risks, and we'll keep talking about it, and but just let you know and that I'm going to bring it up again next time I see you. And obviously my conversations are framed around, you know, my type of job, so please adapt to what your lifestyle is more like. And then these are once again factors for increased risk of both suicidality and substance use. So inconsolable emotion, drastic change in typical behavior, use of alcohol or drugs, suicidal or homicidal ideations, threats or plans, or history of suicidal or homicidal ideations. So now we're switching over to chapter 18, which is more based on like special populations. Okay, and so first off, we're talking about just, you know, any athlete with disability. And first you need to just be familiar with what is their baseline functioning, like what can they do, what can't they do, those kinds of things. And you really don't want to evaluate these people in the mass or like that station setting. And make sure that that any prostheses or wheelchairs or anything else like that fits well. Okay. Okay, so, and then we'll talk a lot about spinal cord injuries. So the spinal cord has 31 pairs of nerves that interpret sensory and motor stimuli and allow movement to occur. And they don't always run simultaneously, okay? So if you have an injury on one side, that doesn't mean you'll lose both sensory and motor function. Non-motor functions are performed by the autonomic nervous system, and the level of the lesion to the cord is associated with the type of disability, typically sensory and motor, and then affects all areas distal to the lesion. So these are the American Spinal Injury Association impairment scales. So A would be like a complete spinal cord injury. B, sensation only. C, non-functional motor ability versus motor function or normal sensory. Autonomic dysreflexia is also known as hyperreflexia, and this is a potentially life-threatening complication for people with spinal cord injuries whose lesions are above T6, and essentially their blood pressure rises and rises and rises to really dangerous levels. And this was the craziest thing I'd heard in a while. I wasn't aware of this, but this concept of boosting, okay, which is this technique used by some athletes who have a spinal cord injury to gain an advantage over an opponent or to improve race times. And they intentionally induce autonomic dysreflexia for the purpose of enhancing performance because they have increased blood circulation. And they can do this by holding urine or clamping their catheters before an event, sitting on a sharp object, sitting for a prolonged period of time, strapping their legs very tightly, or inflicting self-harm. This was like the most mind-boggling thing I'd ever heard of. Just because autonomic dysreflexia is like really, really dangerous. And so, anyways, apparently that's something we need to keep an eye out for. People with spinal cord injuries are at risk of hyperthermia because we can't depend on the autonomic nervous system to lower their core temp by regulating blood flow. And sweating is often impaired below the level of the spinal cord lesion. And so they're at greater risk of heat illness and they need close monitoring. And I don't know if you've noticed this, and hopefully I haven't slipped up at all, but oftentimes in medicine, we tend to label people like spinal cord injury instead of like a patient with a spinal cord injury. And often, and especially with us talking about like, you know, the mental health part of this, we need to be very careful that people are more than just what their diagnoses are, or more than just what happened to them. And it's really easy to fall into that trap. When I was working as a nurse, one of my specialties was mechanical hearts or left ventricular assist devices, and so we called them LVADs. And so we would say, oh, the LVAD in 34 or whatever. And it's like, no, like it's a person. It is a person first. And so it's just something that I try to be very aware of and cognizant of. Because it does make a big difference to people. But it's like, no, I'm a person. I'm not the type 1 diabetic. I'm not the spinal cord guy. I'm not the paraplegic, like whatever it is, okay? These people are also at increased risk of hypothermia because they lack a lot of those normal warming mechanisms, such as piloerection, which is, you know, where your hairs stand up, shivering, and circulatory shunting. And then the lack of working muscle mass below the level of the lesion contributes to this temperature regulation problem. And then also it depends on obviously the level of their spinal cord injury, but skin breakdown and pressure source can be a huge issue. Okay, and these athletes or individuals with complete spinal cord injuries where they can't feel sensations make them especially susceptible to skin breakdown. Because I don't know if you've noticed, but even just while I've been recording this, I've been shifting around. I shift like how I'm sitting and such, and that's because I notice a certain amount of pressure. But if I don't have that sensation, I can't do that, okay? And so what happens is there's just too much pressure sitting in one spot, and it just lets the skin kind of erode. Other things that are an issue that we wouldn't ever think about would be like if our socks are wrinkled and then we put our shoes on, we would be able to feel that. But somebody with these injuries, if their sensation is wrong, they won't feel that it's pressing wrong. Okay. And then also those circulatory problems then create a further barrier even to healing. And these are the different stages of pressure ulcers, and this is one of the least gruesome pictures I could find. So stage 1 pressure ulcer is just this pinkness here. Stage 2 is it extends partially into the epidermis, but not down into the fat tissue, which is stage 3. Stage 4 goes through the muscles all the way down to the bone. You can see it often on like people's coccyx and such, or heels. Those are big ones. Spasms can occur in lesions above L1, caused by excessive reflex activity below the lesion level. And it's that like sudden involuntary jerk of a body part. And a strong enough one can actually throw a person out of their wheelchair, so it's a big deal. And often these are so frustrating for the people themselves, but it's helpful for circulation, so I guess silver lining there. I'm not sure how excited and pumped I'd be if I just got thrown out of my wheelchair though. Bladder dysfunction is like, and this neurogenic bladder can happen with a lot of different neurologic diseases like multiple sclerosis and such, is when the bladder does not always empty properly or completely, and this can lead to infections, kidney stones, and obstructions. So it's important that we're aware of what their bladder management plan is. Like, do they have a catheter? Do they have ureters? Like, where are they able to void on their own? Spina bifida, meanwhile, is a congenital spinal cord disability in which the neural tube fails to close completely during the first 4 to 6 weeks of fetal development. And this is part of why we have fortified foods in order to make sure there's enough minerals and vitamins just in the daily foods that we eat, and particularly folic acid. So that, because oftentimes women don't know that they're pregnant at about 4 to 6 weeks of fetal development, and so they wouldn't know to be taking, unless they were seeking pregnancy, they wouldn't know to be taking prenatals. And so we want there to be enough folic acids to avoid spina bifida. This one, the posterior arch of one or more of the vertebrae does not develop properly, leaving this opening in the spinal column. And this can cause muscular weakness or paralysis below the deficit. And the most common type is a Meningomocial Myosil, however you say that. And these are the two different ones that they could look like. And it's also about like how much has protruded out. So if you look on the right, like the spinal nerves are out in that outpouching, okay? Versus on the left, it's just part of the meninges. Cerebral shunts can be used to relieve the hydrocephalus if there's buildup of cerebrospinal fluid in the ventricles. There's typically no restrictions on activity other than like you don't want to do anything with like head injuries like soccer or anything like that. Latex allergies, I thought this was kind of interesting that your book specifically brought out spina bifida. Patients should not come in contact with latex, but I would say anybody with a latex allergy should not come into contact with latex. It's pretty straightforward. This is polio, okay? As far as vaccine preventable illnesses, this is a pretty great one, okay? So polio is a form of paralysis that's caused by a viral infection that affects the motor cells of the spinal cord. Okay, sensation as well as bowel and bladder control are not affected in polio, which is, you know, both a blessing and a curse. So one of the things that can be very hard for paralyzed people is if their sensation is intact. It also means pain, okay? It means a lot of pain. And it can also be very frustrating to be able to feel the pain and have your body hurt you so much, but you not be able to move it or do anything about it. And the severity and degree of paralysis in polio depend on the number and location of the motor cells destroyed by the virus. In America, we don't see polio anymore because our vaccination rates are so high, but it is still occurs in some parts of the world. Cerebral palsy, meanwhile, is a chronic neurologic disorder caused by a lesion in the brain that affects movement and posture, and typically occurs before, at, or soon after birth, but it's not hereditary and it doesn't typically progress. But it affects the ability to move and maintain balance and posture because of damage to the areas of the brain that control muscle tone and spinal reflexes. These are some of the different types of cerebral palsy. Spastic, which is where you have hypertonic muscle tone during voluntary movement. You can have, constant purposeless, unpredictable movements, or even balance and coordination disturbances. And then seizures. I think we've talked a little bit about seizures in the past, but seizures are more common in patients with cerebral palsy. And it's so important that people are compliant with their medications. And then also that everybody that's either prescribing the medicines know that they are, because there's a lot of medicines or even street drugs that can lower the seizure threshold. So it takes less of a stimulus to send somebody into a seizure. And also important to know, like, your seizure recovery position, lay them on their side, okay, so they don't aspirate. Never put your hands anywhere near their mouth. And these are just some of the pathologic reflexes that can be present. The one that I think is and sometimes these are normal, like at a certain age. The one that I think is funny is the fencing reflex, because like I can get my baby to do it, where essentially like she'll rotate and flex and then go like this. Oh, you can't see, but she essentially like assumes that on guard position, and it's kind of funny, mainly because it's still a normal reflex for her. But all of these are ones that you can that in older people would not be considered normal. And then thinking about amputations. So prostheses are allowed, but no other assisted devices is allowed. And AE is above the elbow, AK below the knee, BE below the elbow, BK below the knee. And it's quite the difference if this, I need to go this way. It's quite the difference for prosthetic if my elbow joint is still intact, okay, or if my knee joint is still intact, okay. That makes a huge difference on the functionality of that prosthetic. And then sensory disabilities, communication is always the struggle. And here we're talking about either people that are blind or deaf or anywhere on that spectrum, okay? And there's different things that can be used in order to help these people still participate. Like this is one of the coolest things ever, are these running guides and such. These kinds of stories are just really inspiring. Glaucoma, meanwhile, is an increase in pressure in the globe of the eye, caused by the inability of the intraocular fluid to drain properly, and it can result in vision loss. Okay, oftentimes can be related to diabetes, but can occur outside of that as well. So if any of your athletes have glaucoma, they must avoid isometric activities, swimming underwater, inverted body positions, excess fluid intake, antihistamines, or anything that would increase eye pressure. Deafness and hardness of hearing. Important to note that it's up to the practitioner to find alternative ways to communicate. It's not up to the patient or the athlete to figure this out for you. Okay. And also important to remember that hearing aids do not clarify or make speech sound clearer. They simply make the sound louder. Okay, this is an example of a cochlear implant and kind of how it works in order to help amplify that sound. And then talking about intellectual disabilities, formerly called mental retardation, okay. And it's significantly reduced ability to understand new or complex information and to learn and apply new skills, which, I mean, yeah, anyways, that's a different conversation. And and when you're talking with these people, it's best to, use terminology and directions that are used, that they need to be clear, short, and understandable. Okay. And oftentimes, in your guys' scenario, you're talking about people with Down syndrome. And Down syndrome people can have an awful lot of laxicity in their ligaments and muscles, particularly in their neck. Okay. And this is something that needs to be evaluated before sport participation is approved. Okay, so this wasn't in your book, but this was something I felt I needed to address for you guys. I'm not sure how common this situation is, but I wanted you to be prepared if it does come up. And this would be both for in your professional and your personal life, okay? So with the Me Too movements and kind of, the cultural and political atmosphere out there, more and more people, men and women, are speaking up about their experiences. And sometimes it can be very hard to know, how do I respond? Like, what on earth do I say? I don't want to make it worse, those types of things. And I'm just looking back to like my own athletic trainers and such when I was playing sports, and they really became a confidant to me. Like, and when I was like either rehabbing from an injury or I had another concussion that kept me out, it was really, I ended up speaking with them a lot about really how I was doing, like not just physically, but like emotionally and such as well. And so I wanted to include some of these things in order for you guys in case this situation arises. So these are some examples on how do you respond if someone tells you they've been a victim of sexual assault, okay? And the biggest thing to think about is we're not the jury in this instance, okay? We are not the jury to say yes, no, he did it, she did it, whatever, okay? At that moment, you are there just to listen to that person. So it's important to sit down. You're a lot less threatening when you're sitting down. You want to listen non-judgmentally and choose words that support and empower them, like, thank you for telling me. It took a lot of courage to share this with me. I'm sorry that this happened. That must have been really tough for you. It's not your fault. You didn't deserve anything. You didn't deserve this, or you didn't do anything to deserve this. You're not alone, and I care about you, and I'm here to listen or help in any way I can. And I wonder if there's anyone you'd feel comfortable talking to about this. And then you decide what you think is best for you. There's an awful lot of people who decide not to press charges or go any further simply because they don't want to go through it again. And there's often, when you do report something, there's an awful lot of like character attacks that go across that too. And we've all heard the ridiculous phrasing of, oh, well, what was she wearing? Those kinds of things, which in the end scheme, it really doesn't matter. And just some more phrases to avoid, okay? You should be over this by now. Why don't you remember everything that happened? You really need to report this to the police. And it's okay to explore whether the patient has or wants to report it to the police, but you need to empower them to make that decision, okay? It's probably a good idea not to tell anybody that they really need counseling. Why did you or didn't you? Essentially, like, why did you invite him over so late after you'd been drinking? Or why didn't you fight back? Why didn't you call the police? Those kinds of things, okay? So the more that you can just sit with them, be non-judgmental, and just say, I hear you, the better it is. And really, like, most of these, like, I think are pretty self-explanatory, like, just don't be a jerk. And oftentimes, just let them do the talking. And then lastly, avoid using touch to comfort them. These people are often like, their personal bubble is quite big. And be prepared to, offer resources and follow up. And for you guys, that could just mean like, you know what, hey, if you want to talk about this again, I'm here. Hey, if you want to talk to somebody like a counselor or police, I could help get you in touch with those people, those types of things. Alrighty, guys. It was a pleasure working with you this semester. I think this is my last official lecture with you guys. And so just remember, I'm not anxious. I'm just extremely well educated about everything that could go catastrophically wrong. Don't worry, you guys will be great. Hit me up with any questions or concerns.